Over the past few months, there has been talk of insurance companies instituting prior authorization requirements for important preventive medicine procedures, such as screening colonoscopies and diagnostic colonoscopies. If instituted over time, prior authorizations could cause delays in providing healthcare and drive up costs. Healthcare systems and private practices would need to hire additional administrative staff just to take on this paperwork burden. Gastroenterologists nationally have been urging American health insurance companies to work closely with gastroenterologist leaders at the American College of Gastroenterology, the American Gastroenterological Association, and the American Society for Gastrointestinal Endoscopy to get their continued input so that we can provide the best possible care. As a gastroenterologist community, we breathed a sigh of relief when United Healthcare's recently proposed new prior authorization requirement was changed to just advance notification. However, gastroenterologists still have many concerns about the impact advance notification requirements could have on providing efficient healthcare. The advance notification process increases administrative responsibility for physicians and gastroenterology practices. Prior authorization and advance notification have the potential to cause delays in cancer diagnosis for patients with alarm symptoms. Instead, gastroenterologists and primary care physicians want to focus on expediting care. Gastroenterologists hope to eliminate red tape so that our patients can quickly get the medical diagnostic and preventive medicine care they deserve. Gastroenterologists hope to eliminate any form of prior authorization because it makes our jobs tougher. It causes delays in patient care. Many of us spend between 20 to 30 minutes advocating on behalf of patients just to get a simple endoscopy or imaging procedure approved. A better way would be to improve the electronic medical record documentation when ordering tests so that all requirements are already documented in the actual order. I recommend working with your IT programmers to maximize the efficiency of your ordering system. Here are a few pearls to help make prior authorizations more efficient. Have nursing staff or a medical assistant schedule prior authorizations first thing in the morning or at the end of the day when you aren't managing patients and can focus. If possible, review the insurance requirements to get a particular procedure performed. Like, do you need an ultrasound before ordering a CAT scan? Or do you need a patient to fail PPI therapy for a month prior to scheduling an EGD? That way, you can be more successful at advocating for your patients and be more efficient with your time. Pesky, time-intensive prior authorizations may lead some patients to potentially abandon important colonoscopy and imaging procedures due to authorization difficulties. Instead, we need to be developing ways to fast-track patients with alarm symptoms and increasing the bandwidth of the healthcare system. I recommend great communication with patients throughout any prior authorization process so that patients don't become frustrated. Medical staff can be super helpful to maintain contact with patients and help you as a physician keep track of any outstanding procedures that haven't been performed yet. Gastroenterologists are advocating on behalf of patients to eliminate step-up pharmacotherapy. We shouldn't be forced to give medications that don't work as well simply because they are less expensive to patients. Many insurance companies want patients to fail cheaper therapies before they'll approve a more expensive medication. This is particularly frustrating because sometimes the more expensive medication not only works better, but was designed to have fewer side effects. Gastroenterologists are trained to select the best possible medication for our patients with the fewest side effects. We want to efficiently provide medical management when necessary. In situations where you get pushback from insurance companies paying for a medication, I highly recommend that the physician or gastroenterologist schedule a peer-to-peer with the insurance company and review medical data with them. Use guideline papers and be able to reference specific studies in support of your medical plan. Knowing side effects of medications that the patient has already tried and subsequently stopped using because of the side effects can be super helpful too. Gastroenterologists and primary care physicians hope to increase the budget for research grants in America so that we can focus on cancer treatments for colorectal cancer, pancreatic cancer, and esophageal cancer to help patients survive and live much longer. Our gastroenterology organizations help advocate for us in Washington, D.C. However, we need larger voices. Any of us or our loved ones can get cancer at any point. It's so critically important to increase cancer research funding for treatments and to help us as physicians detect cancers even earlier in our patients. I recommend getting on a committee for one of the gastroenterology societies, such as the American College of Gastroenterology, the AGA, or the ASGE, to help us advocate for our patients. Many of our GI societies now offer leadership training programs for those who really want to get involved. For instance, a few years ago, I completed the ACG's Young Physician Leadership Scholars Program. At the end of our leadership training, we flew to Washington, D.C. with our ACG governors and advocated for patients on Capitol Hill, which was an amazing and super rewarding experience. Gastroenterologists continue to advocate for patients with lower incomes. We realize the benefits of the Affordable Care Act, particularly the opportunity to provide screening colonoscopies. Some of us also volunteer at free gastroenterology clinics for patients without healthcare insurance. Some of us also volunteer with refugee and immigrant patient populations. For instance, about 7 years ago, I helped founded a gastroenterology clinic for refugees resettling in Chicago. It was a super rewarding medical experience, and I highly recommend seeking out these opportunities. Through our gastroenterology societies, such as the American College of Gastroenterology, we produce lots of free health education materials. I served on the American College of Gastroenterology's Patient Care Committee for 6 years and love the opportunity to produce brochures and online content that help educate our patients. We have many gastroenterology volunteers who not only design health education content, but take the time to analyze enormous quantities of research papers to produce our gastroenterology guidelines that we use in clinical care every day. Gastroenterologists and primary care physicians realize the need for greater postgraduate education spots and residency and fellowship programs so that we can produce an adequate number of clinicians nationally. One of our patients' largest concerns are the wait times to get medical appointments at some clinics and facilities these days. Our goal is to prevent wait times to be seen in the clinic, scheduled for a diagnostic colonoscopy, or scheduled for a life-saving cancer resection surgery. We urge our national leaders to increase medical education funding for postgraduate medical training. Many gastroenterologists take care of vulnerable patient populations through the U.S. Refugee Program, in clinics that help recent immigrants, and in clinics that provide free care for patients. We also advocate for patients on a local and national level in order to preserve these important healthcare programs. Many of us continually meet with government leaders in the Senate, the House of Representatives, and in the White House. We love advocating on behalf of our patients to increase access to medicine. Thank you to all the gastroenterologists and public health leaders who work so hard to help and advocate for patients on a national level.